it is translated to Arabic as سوء التغذية. So malnutrition means poor nutritional state, and it is very important in surgical practice. Around 30% of all patients with GIT disease having nutritional problems and malnutrition, and it's up to 60% of patients who is having prolonged hospitalization due to postoperative complication having malnutrition. So malnutrition is a real problem facing every single surgeon in the world. It is frequently unrecognized and make the patients more prone for postoperative problem, because nutritional deficiencies having a lot of problems, health related problems for patients gonna have a sort of surgical intervention. Now, what's the aim of nutritional support? So once we diagnose a patient with malnutrition, we have to provide him with a nutritional support. And what are the aims of nutritional support? The aim of nutritional assessment and support, the aim of nutritional assessment is to identify those patients in need for nutritional support in timely manner. So it's not only enough to diagnose the case of malnutrition. You have to diagnose it early before you do a surgical intervention in a timely manner to prevent the problems of malnutrition. And the second aim of nutritional assessments and management is to ensure that their nutritional requirements are met by a most appropriate route and manner to minimize the risk of complication. So if you diagnose a case of malnutrition, then you have to choose the way that you will provide the patient with his or her requirements, the routes, the appropriate routes, and we will discuss this in the next lecture, inshallah. So by this time, we have a very brief introduction about our aim or learning objectives in addition to the malnutrition. Now, once the patient is stop feeding, there will be a problems, or there will be a normal physiological response of the body. So the fasting states, which means stopping the input of nutritional supply, will have an impact on the body, which is normal physiological reaction in short fasting, but it's going to have a lot of derangement on the metabolic and the nutritional condition of the patient. So short fast, which is less than 12 hours, the majority of food ingested in previous meals has been utilized. So the GIT is almost utilizing all the ingested food. And the plasma insulin level fall, then plasma glucagon level rise. And conversion of hepatic glycogen, which is about 200 grams into glucose. So we have a small store of glycogen in the liver going to be used by the process of glycogenolysis. So this is the first response during short fasting. Skeletal muscle glycogen, which is about half a kilo, cannot be utilized directly. Instead, it's broken down by glycogenolysis and converted to lactate, which is exported to the liver to become glucose by Curie cycle. And you have a good information from biochemistry about Curie cycle. So liver glycogen going to be utilized directly by converting it to glucose, while skeletal muscle glycogen is converted to lactate and then by the effect of the Cori cycle, the liver is going to be converted to glucose. More prolonged fasting, then hepatic and skeletal muscle glycogen is exhausted, and then breakdown of the fat store provide glycerol. Okay, so next step here, fat store release of glycerol that can be converted to glucose and fatty acids. So glycerol to glucose direct utilization by the tissues, and glycerol to fatty acids, and in the liver it will be converted to ketone bodies, which can be used as a fuel by almost all body tissues. So in this condition, there is no nutritional input, and the body will depend on destruction or metabolism of the fat stores to produce fatty acids, and the fatty acids converted to ketone bodies, and the patient will depend on these ketone bodies on the its nutrition and the functionality of other organs. And in fact, this what happens during ketogenic diet, when the patient will stop taking any carbohydrates, and then the body move to utilize its own fat by converting it to ketone bodies, and the body will use these ketone bodies as a fuel instead of a glucose. This conversion to a fat fuel economy instead of glucose fuel economy reduces the need for muscular breakdown. So that's a beneficial point where the body muscles will preserve its mass and bulk. Instead of that, the fat going to be utilized to produce the fuel. This is called fat fuel economy. With the prolonged starvation, there is a significant reduction in the resting energy expenditure from up to 30 kilocalorie per kg per day and become 20 kilocalorie per kg per day. Longer fasting, more than a day or more, body store of glycogen depleted, and de novo glucose production occur primarily in the liver by what's called gluconeogenesis, which is production of glucose from the amino acids, especially glutamine and alanine, derived from catabolism of skeletal muscle. So, body will start to move the proteins from the muscles by the process of gluconeogenesis. Amino acids going to convert it to glucose, and it's going to be used. So this is still a normal physiological reaction to short and long fasting. Now, let us take a brief tips about a nutritional regime that should about the normal nutritional requirement by anybody of us. So, nutritional regimes that is used to support the patient with malnutrition should provide the patient with certain essential items and as below: protein, carbohydrate, and fat. That's macronutrients, very important. So proteins, carbohydrates, and fat. All of these essential elements should be included in any nutritional regime given to support the patient nutritionally. Again, about apart from these macronutrients, vitamins and trace elements is very important. They are very important to be included in any regime given to support the patient from the nutritional point of the view. In addition to electrolyte and water, we mix all of these things to make a nutritional regime in certain concentration. Daily need may change, okay, depending on the patient condition. So we have to provide the patient with its body calculated in nutritional supply, but this calculation, this equation can be changed depending on a lot of patient conditions like disease condition, and we have to increase and decrease the amount of the nutritional support and nutritional regime depending on overall patient assessment to prevent under or overfeeding. So if we provide the patient with a regime that is less than adequate for nutritional support, then the patient having underfeeding, and vice versa, overfeeding will cause another problem for the patients. Overfeeding is the most common cause of complication, enteral or parenteral. Enteral means those nutritional supports that given through the oral route. It's not only oral, and through the GIT routes, whether oral or whether by tubes that's connected to the GIT. So this is called enteral feeding. Parenteral means injectable to the veins. Okay, so overfeeding having more dangerous effect on the patients regarding the occurrence of complication than underfeeding. So overfeeding is the most common cause of complications during nutritional support. Now, any patient on nutritional support, whether enteral or parenteral, need to be monitored. And the monitoring is very important in order to increase it or decrease the dose, and again is important for early detection of the complications. That's more common with oral overfeeding. Now, monitoring feeding regimes, we have to look to the patient and send him for certain investigation. We do examination and take some measures on daily basis, on weekly basis, or fortnightly. Now, what are the daily measures, monitoring measures, need to be applied for any patient on nutritional support? First is body weight. You have to weigh the patient daily and record that. And we have to ensure a good fluid balance. So we calculate the input and output regarding the fluid, and it should be in a very sensitive balance. We sent for a full blood count, blood urea, serum electrolyte, blood glucose, and electrolyte content and volume of the urine, and intestinal losses. Again, daily temperature checking is very important. Some measures regarding the monitoring should be done weekly in normal condition or can be more frequently if clinically indicated, like urine and plasma osmolarity. So we have to check of that. Calcium, magnesium, zinc, phosphate, plasma protein, including albumin, liver function test, and so on. These are measures that recommended to be done on weekly basis, and certain other investigation done less frequently. So after having a good idea about nutritional requirements and what are the content of any nutritional regimes and how we could monitor a patient on nutritional support, we have to have a very good idea about the nutritional assessment. In cases of severe malnutrition, the diagnosis is usually easy, so can be easily diagnosed as the patient have muscle wasting and proximal limbs and temporalis muscle, pressure sores, apathy. So no one will oversee or cannot diagnose a patient with severe malnutrition as it's very evident. So severe malnutrition is very evident and easy to be diagnosed. And but the problem with milder degree of malnutrition, that is the nutritional impairment type of that is frequently overlooked. So mild degree of malnutrition is the problem. Why? Because it is not very obvious. You have to assess the patient in order to detect it. Severe malnutrition, the diagnosis is easy, and we go straight forward for correction. But milder degree of malnutrition might be subjected to surgical or medical intervention without diagnosis that make the patient prone to a lot of complications and disturbances. So, how we could assess the patient from the nutritional point of the view? This is called a nutritional assessment technique. We have three or four types of techniques. Three main and one recent technique is added, what's called MUST, M-U-S-T. The first one is body weight and anthropometric technique. So body weight is very important. Body weight, we should notice that it is unreliable in critically ill patients because of what's called fluid retention. Critically ill patients liable for edema and fluid retention because of, for example, capillary and vascular leak, in addition to hypoalbuminemia. So patient is having increased body weight in spite of what? In spite of malnutrition. So not all malnutrition results in low body weight. Sometimes if there is a problem with the patient, critically ill patients might have fluid retention result in increased body weight or normal body weight in spite of severe nutritional deficiency. And it should be compared with the ideal body weight from tables and charts, and in addition to a pre-morbid weight loss. So the weight of the patient before getting sick, and then we calculate how much the body lost from its weight. This will give us an idea about the nutritional status of the patient. Unintentional weight loss more than 10% of body weight in the preceding 6 months is a prognostic indicator of poor clinical outcome. So this is called significant weight loss. Why we said unintentional? So it is not intentional. It's not made by the patient. For example, decrease eating or doing some sort of body slimming or regime for decreasing body weight. It is unintentional. More than 10% over 6 months, this is having a very bad prognosis. Now, body weight is usually corrected for height, and it is called body mass index, BMI, and it's widely available, widely used anthropometric technique is to correct the weight to the height by this equation: weight in kg divided by height in meter multiplied by 2. This will give us a body mass index. There is a normal range for adult, and if it is less than 18.5, indicating nutritional impairment. And if it is less than 15, it's usually associated with significant hospital mortality. So we should carefully calculate the BMI. We said already body weight and anthropometric techniques. And anthropometric techniques is a bedside test to calculate the muscle and the fat stores of the body in the form of triceps, skin fold thickness, mid-arm muscle circumference, bioelectrical impedance analysis for estimation of intra and extracellular fluid. They measure the body fat and muscle mass, means energy and protein stores, and they are unreliable in patients with significant edema. Now, second tool or second technique is the clinical technique. So the first technique is the body weight and anthropometric technique. Now, clinical technique. Clinical techniques, these depends on the relating history and clinical signs to produce what's called subjective global assessment of nutritional status. So clinical means taking history from the patient and do general examination and specific regional examination to detect milder form of malnutrition. Weight change in the history, dietary intake, details of GIT symptoms and functional impairments, all of these going to be asked to assess the patient from clinical point of the view. Now, we do physical examination concentrating on muscle wasting, loss of subcutaneous fat, presence of edema, alopecia, and hand grip strength. So these are giving subjective global assessment. The third technique is the laboratory technique. So the first one going to be body weight anthropometric technique. Second is the clinical techniques. The third is laboratory technique. And serum proteins play a very important role in assessment of a patient from the nutritional point of the view, particularly albumin, prealbumin, transferrin, retinol binding proteins. These are sensitive indicators and can be used as a screening tools. It's not very specific, but it is sensitive, and that's the property of screening tool for malnutrition. So generally, we can have an idea about nutritional states from the laboratory point of the view by sending the patient for serum albumin. And serum albumin, less than 30 gram per liter, is an indicator of poor prognosis in surgical patients because the protein is very important for wound healing and for recovery from the trauma of surgery, in addition to its impact on the immunity. Lymphocyte count and skin testing for delayed hypersensitivity reactions. Again, they are usually abnormal in malnutrition due to the effect on immune function, the effect of malnutrition on immune function. So these are the laboratory techniques. The last recently introduced, what's called MUST or MUST, is Malnutrition Universal Screening Tool. And it's a very complicated tool, was introduced by the British Association of Parenteral and Enteral Nutrition. And the MUST tool depend on body mass index, weight loss in the third 3 to 6 months, and acute disease effect. That will be assessed and having a lot of details here. You have to know the name of this and you have to have a general idea about MUST tool, not the details. By this, we give an introduction. We display some nutritional requirements, and then we use to display the tools or the techniques for nutritional assessments. Now, very important in nutritional syndrome. That's called short bowel syndrome, and it is self-explanatory. So what is short bowel syndrome? When extensive loss of bowel length happens due to any cause, for example, surgical resection, there will be many metabolic and nutritional consequences. So, if the patient having actual loss of bowel, like surgical resection, or sometimes functional loss, part of the intestine is going to be diseased and out of its normal function, and then the patient having a lot of metabolic consequences. Now, what is extensive loss? Less than, if it is less than 1.5 meter of remaining small intestine in adult. In this condition, the patient depend on which part of intestine going to be resected or going to be lost. Now, so what is extensive? The remaining small intestine in adult less than 1.5 meter, 150 centimeter. This is called extensive loss. Okay, so the remaining only 1.5 meter. Now, up to 50% of a small bowel can be lost without permanent harmful effect. The clinical representation is depending upon the site and the extent of intestinal resection. Now, which part? We have the ileum. So it is very critical for fluid and electrolyte conservation and the only site for B12 and bile salt absorption. So if the patient having lost his or her ileum, and then the patient will permanently result in vitamin B12 deficiency and bile salt malabsorption. So even if it is the remaining part of the bowel is intact and the remaining is more than 1.5, but it does have this metabolic effect. Now, the colon, water and salt absorption is efficiently absorb 90% of water and salts. Carbohydrates fermentation for production of medium chain fatty acids. So it's very important. Now, effect of surgical bowel resection. Resection of jejunum is usually well tolerated. This is against the colon and the ileum. So jejunum can be resected with minimum metabolic derangement. Resection of ileum, which is very important. If the ileum less than 1 meter, then it result in steatorrhea, means fat malabsorption, and need oral cholestyramine to bind bile salts. If it's more than 100 centimeters, dietary fat restriction should be done. A regular parenteral vitamin B12 supplement should be added. If more than 2 meters is resected, the most challenging cases and may need parenteral nutrition, means enteral nutrition cannot be used anymore. Why? Because the GIT cannot withstand absorption of important things that should be absorbed by the terminal ileum. So nutritional support going to be provided parenterally. Parenterally means providing it intravenously. Now, what are the complications of short bowel syndrome? So we have a good idea about short bowel syndrome by now, that short bowel syndrome means extensive loss of bowel, and the site where the bowel is lost, whether jejunum, ileum, and colon or colon, is make a significant difference. It's not only the length of the bowel, but it is the part of the GIT lost is very important. So If patient have like extensive resection for any reasons, and then he is liable for certain complications like peptic ulceration. Why? Because of gastric hypersecretions. Again, he's liable for gallstones because of interruption of enterohepatic recirculation, and he is going to have a more prone to renal stones because of hyperoxaluria due to increased absorption of oxalate in the colon. Slurred speech and ataxia. Why? Because of electrolyte, because of vitamin deficiency. How we could treat a patient with short bowel syndrome? We should use H2 receptor antagonist to reduce the amount of fluid secreted by the proximal GIT. In addition to somatostatin analog like octreotide, reduce the amount of fluid secreted by proximal GIT and reduce the GIT motility, so give more chance for content to be absorbed because it's short bowel. We should provide the patient with the proton pump inhibitors to lower gastric pH and reducing the peptic ulceration. And sometimes we use anti-motility drugs like loperamide and codeine phosphate, as we said, to reduce the motility and to give a more chance for a patient uh, uh, with of the fluid inside to be absorbed and decrease the incidence of diarrhea and other complications. By this time, we finish a small introduction about nutrition and surgical practice. And next lecture, next week, inshallah, going to discuss types of nutritional support. So we know what is malnutrition. We know how to assess the patient from nutritional point of the view. We know what should be a content of nutritional regime. Now, how many types of nutritional support going to be discussed in the next lecture? And thank you. You can unmute yourself and ask questions if you have. And I'm happy to have your questions. Any question?